Hey, everybody. This is Barden Greenfield, and I'm a veterinary dentist in Nashville. Used to be in Memphis, and I'm at Your Pet Dentist of Nashville. And today, I'm really looking forward to talking with you regarding something that's important that you deal with your pets day in and day out, and that is periodontal disease. And so, the lecture today and the little discussion we're going to have some videos. We're going to show you some pathology, how I treat it, and it's really your understanding of what is periodontal disease and then how can we save those teeth that certainly can be saved. I think the biggest key and one of the biggest faults that we as veterinarians have unfortunately done is we clean bad teeth. And we don't need to clean bad teeth. We need to treat bad teeth. And so, what I want to stress is you being the general public and also y'all because you're so knowledgeable in the pet field, the expectations of what your pets need to have done when you go to your veterinarian for dental care and to ask the right questions to make sure that the proper procedures are done. And it kind of arms you with a lot going forward as far as making sure your pet gets the quality care they deserve. So, the objectives, what we're going to do today is we're going to talk about the four stages of periodontal disease. We'll hit those, and then how to identify and treat stage two disease, identifying stage three, and what teeth are mostly affected, and how best to proceed with that, and then how to get you involved with home care. So, we've got a lot to go over today. So, buckle your seatbelt. One of the things I want you to know is that periodontal disease is out there in an unbelievable percentage. So, 8 out of 10 dogs have some form of disease we're going to talk about today. What that means is that if you just get in the room, that's a lot of people. 8 out of 10 is a huge percent. If it was 1 out of 10, 2 out of 10, then we're talking about very limited disease. But when you say 8 out of 10 dogs have disease that needs to be treated by age 3, and I would preface that by saying that newer studies are showing that if you've got a smaller breed pet, let's say a Shih Tzu, a Lhasa, a Pug, things of those natures, a King Charles Cavalier Spaniel, small breed pets, that this disease process occurs earlier than 3 years of age. So 8 out of 10 dogs have disease that needs to be treated by 3, and in smaller pets, even before 3. So if your vet is saying, oh, we can hang around and clean teeth at age 3, by then 8 out of 10 of y'all's pets have got some kind of disease. So now you're having to treat disease versus preventing disease. So the name of the game is prevention. That's why you recommend diets, is to prevent gastrointestinal problems. That's why you recommend certain things and supplements, is to prevent things. So you're in the preventive business. You're in the healthcare business as I am. So I think it's important for y'all to know that the smaller the pet, the earlier onset this disease occurs, and it's time to act. So honestly, there's another lecture that I do is really cool. It's about the juvenile diseases and the onset of why it's so important to start early. And my recommendation, as along with the veterinary dental college, is you need to do anesthetic dentistry by year 1 to 1.5 in a small breed pet. For those of you that have bigger breed pets, let's say like these shepherds in this picture, the kind of bigger pits and labs and stuff, you can wait to 2 to 3. I'd rather say 2 because I think 2 is when you really need to start. Because again, by 3, disease is already set in. So here we're going to look at, I'm treating this lecture as if you're my veterinary companion. So this is going to be a high level discussion, but I think that's going to be cool. You can always go back on it when if you need to refresh. So we need to look at what's the periodontium, and that is including 4 different things. Number 1 is the gingiva. So I'm kind of using my pointer and circling the gingiva that is here in F. The periodontal ligament is going to be this part along these little striations. And what that is, it is the shock absorber that keeps the tooth from forming into bone. So here's alveolar bone. This is the tooth, and it's covered by a product called cementum, and that's kind of like spackling on a wall when you're putting wallpaper up and you put a product down. It's like a spackling, and then your wallpaper hits it. Well, this is kind of the same thing, and the cementum adheres to the root. Above that, above the gum line, is enamel. So this area where my pointer is now is enamel. And then as you get to the gum line, there's something called the cemental enamel junction. From that point forward, it's all cementum that's covering this tooth. And that periodontal ligament is that shock absorber. And by the way, this periodontal ligament is loaded with very high, fast A delta fibers, neurological fibers. So whenever that tooth goes under and gets popped, let's say either by pulling, or if you've ever been headbutted by your tooth, all of a sudden you're like, holy smokes, it hurts like crap. That is because those A delta fibers are firing, and that's kind of like stop. Because what it's telling you is it's telling the dog to do is don't do what you're doing because you're going to cause trouble. So I think that it's important. And when we look at the periodontal ligament space, we'll look at that as far as width of disease. So if there's endodontic disease, like an abscess or periodontal disease, this is going to be wider. And then we're going to spend a lot of time today talking about this alveolar bone, because periodontal disease is all about one thing: saving bone. So as your dentist, and you go to your dentist, that's what they're going to do, is they really, really, really work on saving bone. So when you wake up in the morning, first thing you do, is you have plaque on your teeth, and plaque mineralizes very quickly, and it forms calcium salt. So that's that form of sludge that's sitting on your tooth. But more important, plaque is under the gum line. And so that's why you have to use the bristles of your toothbrush when you brush your teeth to get that plaque off. In your pet, it's the exact same thing too. And so plaque will start to mineralize with calcium salts over a couple of days. So it doesn't take long for hard calculus to occur. I'm going to give you something that you may or may not know, and unfortunately, I think your vet doesn't know it. Is it's not about the calculus that's on a tooth that's a problem. It's about plaque. Plaque is what starts everything. Plaque is what starts the inflammatory cascades of events for bone loss and inflammation. And so if you've got a mouth that's got a lot of calculus on it and there's no plaque, then it's not a big deal. Now people look at it and go, "Oh my gosh, that mouth is a mess." Okay, get the calculus off, no big deal. But the plaque underneath that gum line is where the trouble starts, and that has to be removed. So as you're looking in the body, and we do have bacteria in the mouth. We all have it. It's just like on our skin, we've got bacteria in our skin, we have bacteria in our mouth. So initially, they're going to be gram-positive bacteria, and those are the good bacteria. But as disease sets in and as plaque forms and as inflammatory precursors come in, then you start inviting trouble. And that is your gram-negative anaerobes. And those are the ones that have that nasty sulfur smell, that rotten egg smell, or as a friend of mine you would say, that that nasty smell at the penguin house at the zoo. That's those gram-negative anaerobes that have sulfur emitting from them, and those are the ones that destroy bone. So it's very important that we go back and we try to save as much of these and keep these in population and not invite the negative anaerobes. Another thing to note is that plaque bacteria is very resistant to antibiotics. So this is another myth, that antibiotics can treat periodontal disease. That's an absolute fallacy, which we'll go into in a few seconds. So if you had to use antiseptics, plaque bacteria is 500,000 times more resistant to them than in a conventional system. And then you would have to use 1,000 times the magnification of antibiotics to absolutely rid an area of infection, which you can't do that. I mean, that's just like that Nagasaki approach. And so when you go to your vet's office and they say, okay, I potentially have an abscess tooth or I've got some disease, and they go, here's some antibiotics, that's not going to treat the problem. That may minimize it short term for you to go in, at least give your pet some comfort before treatment occurs. But by no means, if someone's going to say, here's antibiotics, that's when you kind of, it's one of the first things you would kind of go is, no, I want this treated. I don't want, and this is not treating it. You're putting a Band-Aid on it from here. You've got to go into the mouth and treat. So as we look at what are we going to do and all the different stages of disease, the goal of periodontal disease is to reestablish attachment and get the mouth back to where it needs to be. So if you've got inflammation or if you've got bone loss, we'll talk about ways that we can kind of get the mouth back to a sustainability factor. And as I mentioned before, and this is the hallmark sign, mechanical removal is the true only way that you're going to get anything removed or inflammation from the mouth. Antibiotics will not work. So again, it is the most overused drug on the face of the earth, and we've developed a lot of antibiotic resistance because of the fact that people have used it indiscriminately. Humans, look at kids with ear infections, chronic ear infections because of antibiotic resistance. The same thing in veterinary medicine. We are antibiotic crazy, and now we're coming to the realization. So most veterinary dentists don't use antibiotics in routine dental care, and it's rarely in advanced care, because when we treat the problem, when we do oral surgery, remove the teeth or treat the roots or graft the area, we use it very sparingly. So just remember that. Here's a picture of our dental periodontal kit, and this is called a Weldon kit. And so I'm going to kind of show you a couple of things. This is a mirror, and then there are different type of hand instruments. This is a scaler, and so a scaler is used above the gum line. You never want to use a scaler below the gum line, because it has too sharp of a point, and it will destroy your underlying tissue. This is called, the one next to it that's purple is a Morse scaler, and that is to do little areas of grooves in teeth that above the gum line where it's really hard for that power scaler to get. The next two, the yellow and orange, are a different kind of curettes. This in yellow is called a Columbia Universal curette, and then in the orange is called a Barnhart. Each one of these are specific and have different, and they're cut on two sides. They're called universal curettes, and they can be used, and I use them underneath the gum line. We'll show videos on that. And the most important piece that we have is the one on the far side, and this is my Probe Explorer. And unfortunately, it's underutilized by many veterinarians when their technicians are doing dental care. So probing, there are different types of probes. So you can see there are different gradations, and there's different measurements. These little notches are measured in 1 millimeter increments. And so for here, that's 1, 2, 3 millimeters, and then it skips, and that's to 4, 5. Here, the one here is in the same kind of thing with the little black representing 2 millimeters, and also one that has a 3 millimeter first, and then 2 millimeters and 3 millimeters. The one that I use is a Williams probe, and this is the most common one that I think is easily to use. The first 3 are notched in 1 millimeter increments, and then I've got 2 more millimeters. And this right here gives me a great standardization of when to do certain therapy. So we look at acceptable probing depths, and it's very important to know how deep to probe without knowing you're getting into pathology. So the canine is 2 to 3 millimeters in probing. Now, so if you've got a pit and I'm looking at a canine tooth in a dog, I can say that a 3 millimeter depth one is certainly going to be okay. So if I'm here at 3 millimeters, I'm not worried. But if y'all have a Chihuahua, if you've got a Brussels Griffon, if you've got something smaller, then really 2 millimeters is about as far as it needs to go as far as acceptable depth, as far as probing. And a cat, for those of you, and we've got 5 cats here at the house, 2 dogs, so we love animals, and in cats it's 1 millimeter, and that's all they do. Cats do not get treatable periodontal disease. That it goes straight to oral surgery. So we look at teeth. I think it's important to know that there's multiple roots. So like this fourth upper premolar has three roots. And in this skull, I'm going to show you the probing spots because you have to do multiple points. So they're going to be like a 6-point probe using this. So we'll see in this video, that's the area between the roots. And that spot right there is between these two roots as well. So I'm looking at the distal root and I'm probing there. I'm probing on the inside of the between the two roots called the furcation. The rostral tooth is called the mesiobuccal root. This is the palatal root. But very importantly, unfortunately, a lot of people miss this little spot right there where my little finger is, where that is between these two roots. And that's significant as far as missing periodontal disease. Now, on a canine tooth, you want to slide it. You don't want to necessarily slide your probe all the way around. You want to touch distally, touch in the middle, touch in the front versus just gliding it across. So I pulled out and I'm checking. For those of you that have dachshunds, and y'all listen up, dachshunds have an innate disease process right here where this area of bone is very thin and it causes a deep vertical pocket, which leads to something called an oral nasal fistula, which means there's a connection between the oral cavity and the nasal passage, and that requires oral surgical extraction of the canine tooth. Here's an anesthetized patient, and I'm just going to show you what we do. And the other thing is we probe after scaling because you don't want your probe to hit calculus and stop and not be able to go deep into that pocket. So this is after power scaling and any hand scaling that's done. You're hearing the beeping, and that's from the patient because it is under anesthesia. All right, you can see, and that's just in that one arch. So it's very important that we utilize probing, and I'll explain that in a minute, as right now. And how do you evaluate these pocket depths? Well, it's important to know that probing has to be done on each one. So I can either do it by probing the tooth itself with my probe and radiography because I want radiography or x-rays to augment my probing. So let's look at a couple of the types of bone loss that are occurring. There's horizontal bone loss, which is bone loss along the long axis of the tooth. Then there's vertical bone loss, which is affecting one aspect of the tooth in a vertical nature. Then you can have a combination of the two, some horizontal with some vertical as well. We'll identify each one of them. This is huge. You have to have 40% destruction of cortical bone before you can pick it up x-ray wise, radiographically, dental radiographs. So what that means is that you may look at an x-ray and go, ooh, I don't see a lot of bone, but if you're probing, you can identify. So your veterinary technician has got to know what they're doing as far as probing is concerned, and then augment that with your x-rays. If you see it on x-rays, it's there, but you may not see it on x-rays. And what we have at my office in Nashville is called a cone beam CT, which is totally different. It's one of the only ones in the state of Tennessee, actually, that we CT all our oral cases, and the cone beam is a very small footprint, and that's part of the dental care we do on every patient. Run it through, and it picks up unbelievable amount of bone loss early. So cone beam is really, really, really cool. That may be another lecture for another time, is doing radiography or cone beam therapy. But for the veterinarians in the Memphis area, and then for all of the Hollywood team that are in all these different states that y'all have, your veterinarians are not going to have a cone beam CT. They're just not. But they should have dental x-rays. I would say this: if your veterinarian is not using dental x-rays on your pet, you need to find another veterinarian that uses it. Ask your vet, hey, I love you, but you mind? I want to make sure when my pet's teeth are clean that and addressed that I get dental x-rays. Another thing is making sure anesthetic monitoring is done properly. Again, another lecture that would be a great one is the augmentation of anesthesia as far as how dentistry uses. Like we have a board certified anesthesiologist at our office, and it is awesome. So we see heart cases, we see liver cases, we see kidney cases, we see cases that have all sorts of diabetics that aren't regulated, and it really makes it a lot easier when Dr. Candy's monitoring them because it just takes the less load off us, and he takes care of the anesthetic part, and the pet wakes up just beautifully. So let's look at horizontal bone loss. So this is bone loss along the horizontal axis. If we look at this x-ray on the bottom right, we can see that the height of the bone is low. You can see these roots are exposed. So ideally, this bone height should be right here along that area. And that area, I mentioned something called the cemento enamel junction. That's usually where that bone height is 1 millimeter from it. This is a cemento enamel junction, and ideally that bone height should be here. And what's happened is it's dropped. So you get exposure of roots, as in this case, and that's called furcation exposure. And whenever you get that, pretty much this tooth needs to hit the bucket. There are very few cases where we can save it. But ideally, if you have across the board like this, horizontal bone loss usually affects multiple teeth in an arch along the mandible or the maxilla. Here's radiographically the maxillary incisors, and you can see this bone loss is significant. Here, the bone loss is almost to tip of the apex of the root. Unbelievable amount. And yeah, unfortunately, this is a case that was sent by a veterinarian for taking care of some other disease. And these teeth right here, especially these intermediate and central incisors, and even the lateral one here, they've got to hit the bucket. There's just no reason to save these teeth because there's so much bone loss. Vertical bone loss, instead of having multitude of teeth along a long axis, usually affects one tooth at a time. And that's where if you see bone loss, if you see this tooth that's normally encased in bone, and there's that periodontal ligament that I talked about earlier that's supporting this tooth, here I'm dropping my probe and man, it goes way down. If you notice on the distal end, there's no bone loss. But on the mesial or forward end, it drops way, 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 way down. And so in these cases, it depends on which tooth is involved. Some I'm able to save, some I'm not. So we'll address which ones can be saved. But if it's like in a single rooted tooth like that, it goes. It's got to hit the bucket. So here is a textbook case of vertical bone loss. This is the left mandibular first molar. This is the second molar. And here I see this pocket right there. Now, this is why you need to understand that why did this happen? Well, the reason being is there's crowding going on between the second molar and the first, right there. And so because of that crowding, plaque and debris are able to just set up shop here. And then when inflammatory precursors come in, it destroys bone, like I said before. Plaque leading to inflammation, inflammatory disease, the interleukins and prostaglandins, all the things that just involve the cascade event of inflammation, and you start to get bone loss. So that is a case of vertical bone loss. Here we're looking at the right arch of a right maxillary canine tooth in an older pet. An anomaly here, which is interesting, is this is a third maxillary premolar with a third root, which normally it only has two roots. So that's kind of a neat anomaly. But here we can see there's really not much bone loss, just a tad here. But look on the other side and look at that bone loss. Now you can see all the way down to the axis. Here, vertical bone loss. Let's look at those. So the right mandibular first molar, one of the biggest teeth in the mouth. Second molar, third molar, and that alveolar bone height is normal. That's what I want. Nice little cupping, which is the way it looks. But look at this other side, on the left side, and see this bone loss involving that second molar, and see how crowded that is. So what you do in this case is we surgically remove the second molar, and we also take the third molar out because we certainly don't want that tooth to sit there by itself. It does cause some pressure changes on the gum and can cause some oral ulcers due to pain because it's sitting out like a little point because it doesn't have the crown up here that normally protects it. And so we take that second molar and third. This is an anecdote. I hate this tooth. This is a hard tooth to get out. It's like a wisdom tooth. I'd rather take these big boys that are just monsters that every vet's scared of. This one, because the roots are thin and or can be brittle at times. As we go through the probing here, this is called that furcation. And so I'm putting my probe into the area between two roots. And one of the very first signs of periodontal disease is bleeding on probing. So understanding if you start getting bleeding on probing from your veterinary technician and veterinarian, then that's an indication that's periodontal disease. Same thing on the palatal surface of that maxillary fourth premolar. And in a cat, of course, when you've got bone loss like that, that's sayonara. Get rid of it. All right, let's look at the 4 stages of disease. The first one is stage 1 is gingivitis. We're going to hit that and then modify to stage 2, which means gingivitis, there is 0 bone loss, no bone loss whatsoever. So it's the only one that is potentially reversible. As we go through the other stages, now there's bone loss. And when you start getting bone loss, then you start getting tooth mobility. So we want to look at stage 2, where there's moderate disease, and stage 3, which is advanced. How can we save teeth in these 2 brackets? Number 4, stage 4, too far along, those teeth are goners. So if we look at the gingiva on just stage 1 periodontal disease, that is gingivitis. So I've got a swollen gingiva with a lot of inflammation, no bone height changes. So what do I do with those? Well, let's look at what they look like. And radiographically, there's no bone changes, but I see this glistening. I see that kind of shining little glistening along the in it. It's like it's not sexy, guys, but I'm going to tell you, if this is going on, then we need to do some home care and change that. So there's usually edema or swelling of the gingival tissues, but there is no attachment loss or tooth mobility. And this is where veterinarians miss their boat because they do not address that. So what do we do for this? So what we're going to do in this case is this pet needs to be anesthetized and the mouth needs to be cleaned professionally. After that, home care is important. Brushing a minimum of 3 times a week using a soft bristled toothbrush. There are some great toothpaste on the market that you can use. CET is one of them. Pet Smile is the one we recommend at our office. That's enzymatic. But the key is minimum 3 times a week. You can also use rinses, chlorhexidine rinses, 0.12%. So you don't want to get conventional chlorhexidine that you disinfect a room with and use that and dilute it. That's too caustic in the mouth. You want to have the professional grade, 0.12%. Chews. As far as Oravet chews, you can use any VOHC approved chew, Veterinary Oral Health Council. So what I want you to do is get your pencil and write vohc.org. Go online and they will give you the diets, which I'm not a big fan of using VOHC diets because I think diets are other things can be done to keep the mouth clean. But there are chews there. Milkbone is VOHC approved. Greenies are VOHC approved. So those are things that will help in addition to brushing, but a minimum of 3 times a week on brushing will prevent and treat gingivitis. If you only do it once a week or once a month, don't. And if you take your pets to the groomer and they say, hey, I'll charge you $5 extra to brush your teeth. Run away. Don't let them do that, because just brushing your teeth once a month or every 6 weeks isn't going to do squat. It has to be done a minimum of 3 times a week. As we go into stage 2 disease, now we're getting bone loss. So we're getting up to 25% here. It's up to 25% alveolar bone loss. And from that, we don't necessarily we get a little bit of exposure from the roots. And you can see there's a little bit of cupping here that's a little bit more so than normal. But there is initial bone loss, but it's marginal. And then pocket depths can be up to 3 to 5 millimeters. And as we know, we cannot bring bone back, but we can at least make it static and treat it so we can save these teeth. So here I'm putting a probe in this canine of this mandibular canine, and I pull it out, and that is how deep, everybody? That's 1, 2, 3, 4, 5 millimeters. So remember how deep that periodontal pocket should be, 2 to 3 millimeters, no more. So from that aspect, you know that this is 5 millimeter pocket, so it needs to be treated. Plus, it's bleeding. So it's telling you, help, help, help. I need to do something to help treat that mouth. So within that sulcus, within this, it's got a lot of goo. There, if we're looking at, here's the tooth right in here, and there's that calculus above the gum line. As you go below the gum line, then you start getting calculus on the cementum, and that needs to come off. But in addition to that, you have diseased epithelium, which is on the gingival side. And this is where, unfortunately, people or team members clean the roots a little bit, but they fail to treat the gingiva itself. And we're going to show you how that's done. All this has got to come out and allow for reattachment. Otherwise, you're just cleaning this off and the inflammation is not going to go away. So the procedure is called closed root planing. So what we're doing with this is we're using our scaler, a curette, and I'm going underneath the gum line, and I'm raking out and removing that inflammatory calculus that's underneath the gum line. So I'm dropping that. I'll show you the video on this. My curette in and lightly removing, and I can feel it being nice and smooth when I'm done. So root planing takes on different angles. You can go left, you can go right. I just go in just nice scraping motions, and you just want to make sure this whole area is void of calculus to not allow for reattachment. Then you have to subgingivally curettage. This is the most important part, where I'm removing all this inflammatory nonsense that's there. So I'm getting my curette in, I'm flipping the angle of my curette, and now I'm going underneath and I'm removing all this gradu, all this inflammatory disease here. So I'm not addressing the tooth. I've already removed the calculus off the root here. Now I'm going to remove and denude this this inflammatory disease, and take that whole collar off, and then this will reattach. Now, I can also use medication to help afterwards, and one of the products is called doxycycline. So you can use 8.5% doxy into this area after you close root plane. And so doxycycline, or doxyrobe, is the trade name. There are others that we have a pharmacist make stuff for us, but basically, so doxycycline has anti-inflammatory capabilities. Not only is it an antibiotic, but it's also anti-collagenase, which means that it decreases collagen formation, which is what you don't want collagen to come in and for reattachment. It's also anti-prostaglandin, which means the prostaglandins are involved in the inflammatory cascade. So if you can minimize the amount of prostaglandin release in the gingival sulcus, you've got a good chance of reattachment. Also, doxy binds dentin and cementum, which can then have prolonged release, and then it conditions the periodontal ligaments as well. And the goal with all this is to make sure that your pocket formation is going from 5 millimeters down to 2 to 3 millimeters. So when you're doing closed root planing, you want to minimize and bring that pocket down for reattachment. So you need to come back and have this done again and rechecked in a few months. So here, under anesthesia, I'm dropping that probe in. See the bleeding? And this drops, boom, 5 millimeters right there. And that's unacceptable. So looking at the bleeding from that. So what I'm going to do next is I'm going to use my curette, and I'm going to go in and start root planing. So I've already done the power cleaning with the with that power instruments, but now I'm going in and really smoothing out that tooth. And when you feel it nice and smooth, you know you got it. I'm just putting saline in. So now I'm going to scrape and do the epithelial collar. I'm not doing the tooth. I'm removing and denuding underneath that gum line and getting all that epithelial inflammation off. You can hear it kind of holding on to it a little bit. And once you get done, you're able to just feel it go back and forth and slide. When you've done that, then you're going to add your parasitic, your doxycycline. So it goes on right on the tip in that tooth area, and then you have to activate it. So you just get a little bit of water and then pack it in. Gently pack, you don't smash pack it. But you want to use something called a beaver tail. And just lightly pack it in. And that'll secrete all the antibacterial, it does the anticoagulanase, antiprostaglandins. And now I'm going to get this pet back in about 3 to 4 months and re-anesthetize and see and measure. I may even reapply it. Because again, I want that 5 millimeter pocket to drop down to 3. So in that case, we don't want to brush these teeth on the ones we put the parasitic in because we don't want to pull that material out. We want to use 0.12% chlorhexidine rinses twice a day, and also those VOHC approved products as well. You can take a screenshot of this screen for you. And then I want to recheck that pet in 14 days and then talk about a home care regimen. I never say, here's your hat, what you hurry, get out of here and I'll see you next year. We are bought in with clients as far as when we want to see them, and we evaluate patients, every few months to see how things are going. And then in a stage 2 case, in 3 to 6 months, they need to have another anesthetic procedure. Good news, I don't have to take x-rays. I don't have to do a cone beam. I mean, a very simple anesthetic procedure. As long as they're healthy, I just want to make sure that mouth is getting to that spot where I can get them in once a year instead of every 6 months. The idea is I want to reattach, and I'm preventing further bone loss. All right, here's some cool stuff. We're going to talk about stage 3. Remember, stage 3 periodontal disease is 26 to 50% bone loss. Look at this deep pocket off this. So as I mentioned, most likely this tooth has got to go, but how we still have to treat this pocket. And how are we going to do that? We're going to go ahead and graft it. This is on a right maxillary canine tooth. This is on a case I published in the Journal of Veterinary Dentistry a few years ago about this humongous pocket that's there. And then so we're going to graft this area, and that's vertical bone loss here. You can see it going up in that whole vertical area. So indications for open root planing and either bone augmentation, which means bone grafting, and also using something called a guided tissue regeneration, or GTR. And GTR is to help prevent what we call epithelial downgrowth, where the epithelium or of the gingiva will downgrow into the tooth root and then allow for inflammatory disease to follow it. We don't want that. GTRs prevent that from happening. So these are for pockets greater than 5 millimeters, but under about 7 or 8. So it's that sweet spot of bone loss. And especially the tooth is moving a lot, you're not going to do this. But if we can reestablish bone on it, it very well may work. And so what teeth do we pay attention to? Well, the one of them is the palatal, or that aspect. Remember I told you about those dachshunds, that maxillary canine tooth on the palate side, the tongue side of the mandibular canine tooth, and then that first molar tooth that I just showed you the x-rays of. Before we go into grafting, we always want to make sure the owners are compliant, because I don't necessarily want to spend a fortune on doing bone grafting and augmentation if they're not willing to try to keep the mouth clean. But most owners are wanting to be compliant, so I think this is going to work really well. And then we follow suit. The equipment that you're going to need are obviously those probes we talked about in your curettes. You're also going to need a complete oral surgical kit, and then the suit you're going to use is going to be very fine. And then also we're going to use some decalcified freeze-dried bone, which is called osteoallograft, and then whether or not we're going to put a bone matrix for guided tissue regeneration. So here is that dachshund. Palatal aspect, vertical bone loss. Look at that crater. That's a monster. As long as this doesn't go into the nasal passage, which is an oral nasal fistula, I could potentially save it. So I'm going to use I'm going to show you videos, but this is just the products. This is the bone graft material and the GTR, and that's when it's placed in, and that's even using a GTR that I would place afterwards in some cases and fit in and close. But I'm going to show you, and here's in the case where 6 months later, I've got total reattachment of that area that before was totally voided of bone. So here, let's look at one. Look at that bleeding. You can see that in, and it's not into the nasal passage. One of the things you can tell if you're worried, if your vet's worried, is to get fluorescein, which is what we use to stain eyes. If the eye has been scratched, a cornea has been scratched, I can get some fluorescein and some saline and shoot it in that area, and then turn the head down a little bit. And if it comes out, turn out the light, put a Woods lamp on, which is an ultraviolet light. Now, if you see it coming out of the nose, tooth's got to go. But this is assuming there is no bone loss. So this is how we're going to make a flap. We're going to make a lunar flap and expose this. So this is periodontal surgery, and it's going to bleed. And I'm going to elevate this tissue. See, I'm now getting it off that tooth, and now we've got to control the bleeding. I'll use a suture, is a stay suture. And hemostasis, now you can start to see it. See how the defect is here. I've removed that gingiva. I'm going to clean that whole gingiva up, by the way, if I've exposed. And there's that monstrous defect. And so sometimes I'll put a piece of suture here and pull it back and to retract. So I'm going to use my scaler that is meant to go underneath the gum line. This is a professional scaler. It's got a periodontal point to it that goes underneath. Here's a suture I've used to tie on this to pull it back to retract so I can get good access. Once I use my power instruments, then I'm going to use my curettes. See that junk coming off? That's really cool. right there, that's all that epithelial crap that's sitting in there. So if you don't get that off, you're just gonna have some reattachment problems. And this tooth moves just a tad, but once I get that grafting in, it'll reattach. So now I'm cleaning the bone side of that tooth, and I'm smoothing that out. And watch this. Here's some more of that crud. Whenever I see that, I know I'm doing a really good job getting that inflammatory disease out. And now I can start putting my graft in. So I'm cleaning the edges. But I need to make sure I'm able to surgically close it. But see, I'm getting some of that inflammatory disease off. And here I'm mixing now my graft. This is sterile grafting, so I have to be very careful. This dish here that I'm transferring it in is sterile. And now I'm packing this material into the defect. And I want to keep it at that bone height margin. So I don't overpack it. And also now this area right here is nice and smooth. Now I have to reattach it, so I have to make sure I didn't cut too much of it. I'm going to do what we call a sling suture now, which I'm going to back up a minute. So the suture is interesting. It starts from here and slides to here, back, and then back around. And so it's going to be like we call a purse string suture. So I'm walking this suture now to the back end, and that's going to tighten it up, and it's going to bring that palatal gingiva snug up against that tooth, which is what I want. And now I'm going to bring it back. So I'm making what we call like a purse string. It bleeds. It's kind of gross, but cool for me. And so now I've got two sides. I've got the side that I started with here. I've got the little leftover piece that I started here, and I went all the way around, all the way back, and then I was able to tie a knot. And that knot ties right there. And that's it. It makes it really snug. I get this pet in. I get them back in about 3 months. I anesthetize again. And then the only time I'll use antibiotics is if I feel as though the pet is immune compromised, either with other diseases. It's rare. When I do use grafting material, sometimes I do. But again, they're going to go through the same treatment. We're going to have them use rinses. They're going to be on chews. And then we really talk about saving that tooth going forward, anesthetizing, and getting them back in. So it's really cool. I wanted to see on stage 3. Now, on many stage 3 cases, you have to surgically remove the tooth. If you've got 50% bone loss in certain areas, it's got to go. So these are just those instances of teeth that I can save. But in many cases, stage 3 disease, you have to remove the tooth. Stage 4 periodontal disease is called toothanasia. It's basically teeth have got to go. So, for goodness sakes, if you've got mobility and a lot of incisors and just hanging on, or other teeth that got disease process, get them out because it's putting a lot of pressure on your pet's heart, liver, lungs, and kidneys. And certainly those diseases, when it's that far along, you've got over 50% bone loss. That is when you have to take the teeth out. Absolutely no other way to do that. So now I'm sure you have some questions that I'd love to answer. So I know you'll be able to write them down or send them to me and I'll address them. So I look forward to answering as many as I can for y'all. I hope that this has been an educational process for you. Get to see what we do as veterinary dentists and put you into the seat of what I would normally lecture. This lecture is really for DVMs, for veterinarians. So you got a dose of that high level periodontal lecture. And so we really hope that you have enjoyed it. And certainly, again, ask me questions. Be happy to answer them for you. If you have any questions going forward, you can email me at drg@yourpetdentist.com. And certainly it's been a pleasure. Again, I'm very impressed with all what Hollywood has done for all the communities in the Southeast that I've seen. And it's kind of cool when I lecture across the country. It's just amazing. I'll drive around and lo and behold, what do I see? A Hollywood feed. So you're doing a good job and keep it up. Y'all have a great day. And I hope to be able to talk to y'all soon. Take care.